So, Salam alaikum, and thank you very much for the invitation. I'm going to talk about the high energy fractures of the thoracolmbar region. I'm an associate member of the AO Knowledge Forum Trauma. And the outline I'm going to talk about are four things. First of all, the AO spine classification. Why is it interesting and necessary? Then I'll proceed with the non-controversial management. The AO provides us treatment principles I find very valuable to plan our strategy. And then last but not least, I'm going to talk about current controversies. So the AO spine classification, why is it so useful? When you think about any injury, we recognize different patterns they repeat. So the AO spine classification tells us an A fracture affects the anterior column, and B fracture affects all three columns, especially sometimes with a PLC injury. And a type C fracture, most devastating fracture we can face. And the AO spine classification is hierarchical, so we know an A fracture is more stable than a C fracture. And a C fracture is more severe than an A fracture. So when we have the classification and we give it a name, we all have an image in mind. So this is why it's very helpful and necessary. And moreover, we have comparable outcomes. So therefore, we can tell if I treat an A0 fracture, I know conservative treatment will always be successful. The patients will have pain, obviously, because it's a fracture, but there's no need for surgery. Same accounts for A1 fractures, and the same accounts for type C injuries. So I'm going to show you some cases, and type C injuries, they need surgery. So like in this patient, devastating injury, he fell from 3 stories as a construction worker, type C injury. I did posterior fusion with decompression, and surgical stabilization is warranted. And how do we treat those patients? The AO Spine just recently published guidelines based on a systematic review, and they say, and this is more or less common sense within all surgical societies that provide us guidelines, we would opt for surgery within the first 24 hours. Time is spine is one of those words that is out there. We want to be fast. Second thing, blood pressure management. The evidence for that is low. When you're also interested in degenerative or deformity surgery, you know when you have traction on the myelin, you increase the blood pressure, most likely your outcome will be better, or even if there's a deficit, reversible. So therefore, this is a more recent concept, only 14 studies in the systematic analysis from the AO, but there is a recommendation to maintain a blood pressure between 75 and 80, not higher than 95 for 3 to 7 days. Also published recently based on a systematic literature review. Cortisone, I use it. However, any society presenting guidelines says it's obsolete. So if I would have an injury like that, I would like to have the cortisone. You can give it to me. However, the data is not that good, and therefore the guidelines state you don't give it. So next case, also C-type injury. And this is how we usually manage those patients. If it's in a more mobile region, so thoracolumbar lower region, we opt for anterior support as well. Decompression posterior with anterior support. So C-type injuries, the management is more or less clear. Type B injuries usually require surgery. And this is because the stability of the spine is impaired in all 3 columns. So like in this patient, you see there's a clear involvement of the posterior facet. It's an unstable injury, and I did a percutaneous posterior fixation from above and below with anterior support surgery. But what happens if we treat them conservatively? So this is a young patient, 36 years of age. He fell from the second floor, had multiple injuries, and he was treated elsewhere. And he was referred to me 1.5 years after the incident with excruciating back pain. And when I looked at the X-ray, I saw this might have been a missed B-type injury, because all the reports before that, they didn't state that there was a B-type injury. So when I look at the distance between the interspinous process, it differed vastly. This is the full standing X-ray I did in my clinic, and you can see 40 degrees kyphosis in the mid-thoracic region. And in the CT, the same day, we see it's 10 degrees less. He had excruciating pain, and I had no neurologic compromise. What I did was a correction and fixation from posterior with fusion surgery, only posterior fusion surgery, and the pain went away. I've seen in 1.5 years after surgery now he does fine still. Another example for a B-type injury, and I want you to emphasize this very well. The MRI is helpful in finding B-type injuries. You see the posterior ligament, the posterior black line disruption, and it's an A4 fracture in the front, but an B2 fracture when you do the MRI. What I did was, again, posterior percutaneous surgery, and you can reduce those fractures very nicely with percutaneous monoaxial screws. And then I did the anterior corporectomy. Patient does fine. So why do we do the things we do? I find those principles from the AO very helpful, because it gives me a guideline on how my treatment plan should be. We want to achieve the best possible stability. We want to realign the spine, just the same as in the deformity surgery. We want to respect the biology of the spine, so I prefer to go minimally invasive if ever possible. And we want to maintain and restore the function. And obviously, stability and function, they have to be balanced against each other. So having these principles in mind, I'm coming to the controversies. And the watershed line and the largest controversy for treatment seems to be between A3 and A4 fractures, so incomplete to complete burst fractures. We made a survey within the Knowledge Forum and found, yes, we are divided. So when we asked experts for spinal trauma, 60% would prefer to treat A3 fractures conservatively. A4 fractures, it's the same proportion, but different way around. So 60% of international experts would prefer surgery for A4 fractures. However, even though we don't agree on the exact technique for the fractures. So I'm going to skip that, because I will present you the results within the next talk. And I want to share with you the Bernese way of treating A3 and A4 fractures, because it's very similar in our practice. You see, this gentleman is also a construction worker who fall from a construction site with this A4 fracture. It's more or less an incomplete burst with a coronary split. So we see this quite a lot, actually. When he was mobilized, he had irretractable pain. Therefore, we opted for surgery. And as I explained to you earlier, we used to do percutaneous fixation and reduction with monoaxial screws. And in case of A3 fractures or A4 fractures presenting only with a split, we try to preserve the more or less healthy disc. Because the injury is obviously there, but we want to give the disc a chance. Maybe it won't degenerate after trauma. So therefore, we do a hemicorporectomy with 2 split screws. Those are lag screws to bring some compression on the split. And you see this is after 6 months, the CT scan, there's a complete fusion in the anterior aspect. And after that, we're going to remove the posterior instrumentation to maintain the largest amount of stability, of mobility. Again, respecting the AO spine principles. So to conclude my talk, classification is important because it means common language and significance for treatment. When we have patients with neurologic deficit, time is spine. So in my practice, they will get immediate surgery. The AO principles, stability, alignment, biology, and function, they influence my treatment recommendation. And I think what's really important, if you're not sure about the posterior ligamentous complex, do additional imaging, like an MRI, like functional radiograph, because PLC injuries are really important on the long hand. So thank you very much for your attention.
The next talk is, I think it's an abstract presentation about the surgical versus non-surgical treatment of thoracolumbar burst fracture in neurologically intact patient and AO spine non-randomized control international multi-center trial. That will be presented by you? Okay, thank you.
So thank you very much. At this point, I have the great honor to be the substitute for Mohammed El-Shakawi, a friend of mine from the Knowledge Forum. Unfortunately, he's stuck in his clinic. He has to take care of a patient. Therefore, I am allowed to give this talk to you. And maybe some of you already knew that A3 and A4 fractures, I talked earlier, are very controversial in literature and also in treatment strategy around the world. When you ask the colleagues from America, they won't operate on any of them. Same accounts for Australian spine surgeons. Usually they will treat every A3 or A4 fracture conservatively. And I found this really interesting because we have a situation around the globe where we have the same injury, but totally different treatment strategies without any consensus. And therefore there was this initiative from the Knowledge Forum to have like a global multi-center study, and it should be observational. So your local treatment protocols that should give the best outcomes to your patients will be comparable around the world. And you see there have been 14 centers all around the world with many, many different strategies and participants. And yeah, this is what it's all about. We have this A3 fracture and A4 fracture, and we included all patients between 18 and 65 years with intact neurology. PLC injury, so B1, B2, we included those patients because sometimes it's not that easy to see is it injured or not. So what we wanted with our protocol was to include all the patients the local investigator thought is an A3 or A4 fracture and compare this treatment. So some surgeons opt for surgery for A3, some opt for surgery or conservative for A4. Patients had to have a patient diary. Every 2 weeks, they were asked how they're doing. Is someone taking care of you? Are you absent from work? Are you already working or not? And the hypothesis was the time to reach the clinically relevant improvement in health-related quality of life measured by the ODI is shorter for the surgical population than for the non-surgical treatment. The groups were allocated a little bit more surgically than conservatively, and you can see Europe, Middle East, and India, we're on the same page, right? Most of our patients will get surgery. However, North America and Australia most likely treat them conservatively. This gives us something to work with. So the primary results. Within the time to event analysis, 12.8% improvement in ODI would be the minimally clinically relevant distance. And in the primary analysis, there was no difference between surgery and conservatively treated patients. This was very astonishing to me. So everything's known? No, it's not. Because when you look into the data, and marked yellow here, patients who have had surgery achieved a clinically relevant difference already at discharge. So after surgery, our patients treated surgically were doing better, relevantly better, than those being treated conservatively. And the minimally disability, it stayed more or less the same over the whole period of time. Only at the end of 1 year, the difference was not significantly. So we found that going back to work and being taken care of is also different. Patients we do surgery on, they go back to work 26 days earlier in average. Although it's not statistically significant, this is a difference, and there is a 13-day difference in pain medication. So non-surgical patients and surgical patients have the same ODI in the primary analysis after 1 year. But patients who get surgery will more rapidly improve in ODI. And so therefore, if you want someone to get back to work early, to be less invalid for a shorter period of time, it might be still beneficial to do surgery. So thank you very much. We are going to make more detailed analysis on that, but those are the preliminary results, and I'm happy to answer your questions.